Welcome to the Equity Plus podcast from CareShare Health Alliance, where we have the hard conversations needed to do the work to advance health equity. We're so excited to have you here today for our very first episode. In this episode, we'll introduce CareShare Health Alliance and our team. First, you'll hear from our Executive Director, Wailing White, about who we are as an organization and the work that we do.
Thank you, Aaron. So just to give a little bit of our background, CareShare Health Alliance was originated out of a collaborative network of partners. These partners were dedicated to connecting the uninsured and underinsured individuals in Buncombe County, North Carolina, with donated healthcare services. This will later expand across North Carolina. In 2008, CareShare Health Alliance was officially established to serve as a statewide resource and technical assistance center to help communities develop their own collaborative networks to improve access to care and the health of low-income, uninsured and underserved people. While working with collaborative networks, CareShare Health Alliance began to realize that, to truly make an impact to our overall health, we could not only focus just on the clinical care, but rather broaden the scope to address additional factors preventing individuals from seeking or receiving healthcare services. So these were termed social drivers of health or social determinants of health, as some people call them. But of course, affects individuals' health, such as housing, transportation, access to health insurance, being able to receive healthy foods, fruits and vegetables, education, anything that's external of the body of the clinical care that impacts someone's health. While addressing these social drivers, particularly with access to health, we started our work in two major ways. In 2014, CareShare Health Alliance established the NC Get Covered, which is still going today. That was to help North Carolinians get access to health insurance after the implementation of the Affordable Care Act. And also in 2020, through the North Carolina Collaborative on Medicaid Transformation, which we call NC Comment here at CareShare Health Alliance. This program actually supports the implementation of Medicaid transformation in North Carolina. So we typically have always lived in the access to care space, similar to the Access to Care Network, which was Buncombe County. We was the TA provider for many donated care networks across North Carolina, including how I got introduced to CareShare Health Alliance in 2013. I began as the coordinator for Hereford Health Access, which was an Access to Care Network program in Hosky, North Carolina. So since then, we've pivoted and we've changed our scope and sort of rebranded here at CareShare Health Alliance. We still believe in lifting community voice. Our mission is to collaborate for health equity, and through our work of addressing social drivers of health, we became aware of the inequities that are inherent in healthcare systems. These inequities predominantly affect historically marginalized populations, especially BIPOC communities. We recognize that the disparity is due to white supremacist systems that perpetuate structural violence by intentionally leaving out, othering, and harming people of color. So through this realization, we decided to actually dive more into equity, get into the root causes, and actually engaging more with communities and bridging that gap between the systems and communities to make sure that we are encouraging and fighting and advocating for system level change for better health equity and creating opportunities for BIPOC individuals in healthcare and BIPOC-led organizations that are out here in communities addressing social drivers of health, rather through professional development, capacity building, or just creating connections to help these organizations and communities to thrive. So our strategic priorities are a little bit different than they were in 2008. I just want to be thankful for our board of directors, our board chair that has guided us through this new direction, and I would say a new path and journey that CareShare Health Alliance is on. Our new strategic priorities are increasing access to equitable care, disrupting white supremacy culture, developing connections and networks, and improving capacity and sustainability. So a lot of our work is continued to be deep-rooted in community across North Carolina, improving access to care. We have wonderful equitable care that's here in North Carolina. We have a strong medical and health presence within our state. And so we're just happy that we are able to, make those connections, expand our network, and partner with organizations and partners across the state to make sure that we are connecting community members to that equitable health that's being delivered and being provided within our state.
When we envisioned this episode, we saw it as not only an introduction to CareShare as an organization, but also as a way to provide a deeper look into our staff's own lived experiences and how they affect the work that we do. So we created a set of questions based around two of our strategic priority areas. Those are increasing access to equitable care and disrupting white supremacy culture. Our first question is, what does equitable and culturally competent care mean to you as an individual? To start us off, you'll hear from our Director of Innovation and Capacity Building, Jayla Clayton.
When I think of equitable and culturally competent care, I think of care that meets people where they are. So if we're thinking on an individual level, equitable care means that I'm not necessarily having the same one size fits all solutions applied to my particular health needs, but I'm having care that is addressing, my background, my lived experience, my culture, my how I show up in the world as a Black woman, care that is encompassing all of those kind of intersectionalities that I hold and providing solutions for me that are based on my experiences as a person. So I think that's what it looks like on the individual level. And then, on a community level, so a lot of the work that we do where we operate, I think it means that it's care that's informed by what the community has actually asked for. So not a solution that is based on some sort of like standardized idea of this is what health must look like to everybody. But again, like care that has taken into account and actually genuinely listened to what the community has said that they need.
Next, you'll hear from our Executive Director, Whaling, again.
Yeah, I would agree with that too. That was a really good definition, Jayla. I think like when I think about it, it's like a tailored plan for yourself in regards to your individual needs in relation to your culture. So an example for me would be recognizing. So I'm born and raised here in Eastern North Carolina, majority African American community, and we all love soul food here and believe in our barbecue, vinegar based, we'll put it up against anybody in any state, any part of the state. But, just thinking about like our diet here is a big part of our health and like care, not saying, okay, you can't eat this, you can't eat that, but rather try this method in cooking your collards or, using less salt or maybe using Mrs. Dash and being more culturally aware of the type of medical care that's needed because just me and my family, if we had to totally turn our diet away, like that'll be a big blow to our family dynamic and other things as well, other dynamics as well, just as just take into account where people are. In other places, there's food trucks and things of that nature, but we have like mobile units now because there's a lot of people that are lacking transportation, going to where people are and making healthcare more accessible, more tailored, and more in tune with patients and with community members' needs. So I've seen it, firsthand in my experience is it can work and it's what's needed right now.
Now you'll hear from our Director of Community Outreach, Shaughnessy Lofton.
Yeah, I'd have to also agree. Equitable and culturally competent healthcare as an individual. I always think about the social determinants of health and like how medicine isn't just molecular and how we must consider people's lived context when we're developing treatment plans. Because that will affect if the treatment plan is actually sustainable or even possible for, or like like we look at SMART goals, right? And we want to make sure that patients can actually attain that. But we have to consider what they have going on and we have to have those conversations. And so equitable care is having those uncomfortable conversations that will help maximize when people are getting care and they're in that space, or when I'm getting care and in that space, that will maximize the moment, but also like when we think about long-term sustainability, it'll give that security because I'm aware, you have a sense of awareness. And it's no longer the excuse of, I had 15 minutes with the doctor and I couldn't even discuss. No, that's not enough because those 15 minutes could have been transformative for a person who potentially, is struggling with something else, which is causing them to have the medical issue that they're having, but they're not able to really talk about it because we live in a system of surveillance. So just being, nervous of what if and what happens next. actually also making sure that people are comfortable and trusting of the system in that way to even have those conversations. And when the opportunity comes and it's not comfortable, really honing in, engaging in, and using that as an opportunity to really understand and strategize together, so that communities can know, like, you are the center of your health, you are the center of you, and you are the expert. And while a physician may have the evidence base and the science behind it, you know what's attainable. You know your everyday lived experience and why you show up the way that you do. And so when I think about equitable and culturally competent or culturally appropriate healthcare, I think about welcoming people as their authentic selves and not just as patients with an issue that need to be diagnosed.
And now you'll hear from me, Director of Communications, Erin Story.
I think for me, equitable care, I think of it really as access to care just because of my background. Like Wailing, I'm from the eastern part of the state and I'm from very rural areas. So we experience a real lack of being able to have providers in the area, especially the consistent providers outside of just having, like a family practice doctor. If you needed to go to a hospital or a specialist, you would have to drive at least 30 minutes away. So for me, that's really shaped how I view equity when it comes to healthcare, is to make sure that everyone has reasonable access to the services that they need.
I wouldn't even look at it as like culturally competent care. I would look at it as a care system that practices on the continuum of cultural humility. There's no expert of culture because culture is ever evolving. Generations are shaping what does new look like. And so I think more than anything, community-centered care, patient-centered care, family-centered care is a way to practice that cultural humility aspect, because we have three Black people on our staff. All of our stories are different, so it wouldn't be fair to assume just because we identify all as Black that we have the same practices, because we all engage with our community differently. And so I think it's given that space for people to understand there's power in lived experience, and also for them to share their story, that will help inform how can I keep the care that I'm providing to you. How do I keep you centered in the middle of the care, rather than the issue or the problem or disease?
Yeah, Shaughnessy, and I love what you said too about being able to give culturally competent care doesn't necessarily mean like one day the field of health will have just magically like understood everyone's culture and can be an expert in everyone's culture and be able to expertly deliver culturally competent care. I think it's, and I think this is something, actually, Shaughnessy, shout out to you, because this is something that you have taught me just in the course of this work, viewing equity as a process and not a destination. That also factors in there. And that when we truly have systems that, have changed to the point where care is patient and community centered, then, naturally and organically incorporated into the process is that cycle of evaluating, like, okay, is this care that we're delivering to the specific community? Does it make sense for the times that we're in, and as we all know, and living through the unprecedented times that we're living through right now, a lot can change in a year. So what is the process for constantly putting the community at the center, constantly listening to the community because we've put them at the center, and then adjusting, not in a way of like, okay, we're working towards this destination that we will have a perfect understanding of everything this community has ever told, but that we're in a relationship with this community where they know that they can trust, that their care systems are listening and responding in a way that is not like burdensome to do that adjustment, where communities are not just being tolerated in that process of adjustment, but where they're actually being uplifted.
I would also say, like, if we focus so much on like the competency side of things, then it would become a checklist rather than an organic process. And I think with cultural humility, it provides a space where change can occur and it's okay and accepted. Whereas cultural competence is like, I'm a mastermind of this. Like I've studied your culture, and because of this, you do this. No, because everyone engages with their culture differently. So really just looking at it as a continuum, but also I think we have been far away from having conversations about change, but change is going to happen regardless. And so being open to that and understanding that change comes from people thinking differently, people having different experiences. And so, how, as a profession, can we meet people where they are? That's equity, right? Like, really meeting people where they are. And then also, like, not looking at it as a disadvantage because we basically created the standard practice for this type of people. But we know that people are complex and people deal with wicked issues and wicked problems that are really hard to figure out. It's very complex. And so, how can we create systems that are going to be open to the complexity of people? No two people are the same. I don't care. Me and my mom are two different people, just like me and my dad are two different people. The treatment plan for me, regardless if we have the same disease, may be different because of my lifestyle, my behavior, my social environment, how I work, who I have insurance with, if I'm employed. We just have to be open to understanding that the human being is so complex and there's never going to be a cookie cutter shape to fit all.
And also, I think that's one of the reasons that's so important to have an open dialogue with the community as well, so that you can continue to learn from them what their needs are, so that you can continue to provide them and develop the resources for them that are needed.
Yeah, and it's another thing, like when we think about implicit biases, if we don't give people time to communicate their lived experiences, we're just going to be leading by what we think we know subconsciously, just based off of our engagement or observation. So I remember there was a study through Harvard that did like implicit biases with looking at implicit bias across like physicians and treatment options and things like that. And it showed like there were implicit biases for Black and brown bodies that then physicians were like treating the patients with a different medication just based off of their phenotype. But that phenotype doesn't give lived experience. It doesn't tell you about a person. And one of the TED Talks that I love the most is it's about a single story. What is it? It's I forgot what it's called, but it's really good. And it really, debunks like the harm of assuming, the harm of what we have as subconscious thoughts and implicit biases because we are human. But how are we navigating that when we think about larger system change and like long-term equity? And like Jayla said earlier, like equity is not a destination, it's a journey. Like there's never going to be the perfect spot because you can't please everybody. But how can we open our systems to having those types of conversations?
To both of what you're saying, Shaughnessy and Aaron, and where we talk a lot about in our work, structural empathy. So in the field of public health and in healthcare, we've heard a lot of discussion around the effects of structural violence, or like, the effects of a system that is violent towards certain communities, certain historically marginalized communities. So what is the response to structural violence? We think of that as structural empathy. So how can we as CareShare be having conversations and, building movements that move us more towards that space of a structure that is empathetic towards people's lived experiences, and a structure that, rather than trying to point the finger at somebody for individual or community level shortcomings, it's how can we take that assets-based approach and look at what is here, look at where what is working, and amplify more of that and kind of more positively reinforce. And then to have the basic building block of what empathy is, like, showing up for people that if I was down on my luck or, in a situation where I'm needing support from my neighbor or my community, I would hope that someone would reach out a hand to me and, help me out. How can we create more of a culture, around structural empathy rather than that structural violence?
So our next question is, since we've discussed structurally empathetic systems as opposed to structurally violent systems, What would a structurally empathetic healthcare system look like to you?
To be structurally empathetic, it has to be made so that the patient can receive as much individualized care as possible. So if the patient is from a marginalized group, like for example, I'm part of the LGBTQ community. And one thing that when I go to see providers, I will seek out if they say that they're LGBTQ friendly. Otherwise, I don't really feel comfortable sharing with them. So I would think for me, being in an empathetically structured healthcare system, that would not have to be such like a burden on myself to be like searching through their little profile, seeing if they have a little rainbow next to it or, something like that. And then going in and being able to discuss my issues and having them, spend time with you so that you don't feel rushed. There are a lot of structural reasons why the doctor only spends like 15 minutes with you, which is outside of their control. But, being able to spend time with the person, having a consistent provider, something like that, I see as an empathetic structure.
Yeah, and so my my first thing that, as you were saying, that I was thinking about was a 15-minute appointment at your doctor's office. There's no way to get, and especially if we're considering, say, if it's your first time visiting this provider, and like you said, like I know that they're under certain, requirements for that are beyond their control, but also too, then that's like, okay, well, let's look at whose control is it in, and why has this become the norm? And then, yeah, like I was saying earlier, within that time frame, there's no way you can give full, comprehensive, and in a conversation that it's actually building trust between you and that provider, but a comprehensive like scope of your medical history, scope of what's going on that you're needing support with. There's no way to do that. And then I think too, another side of that too, like from the insurance perspective, unfortunately right now, I feel like that is another space that is definitely playing into a more structurally violent system, just with people not really having a great understanding of what will be covered by their insurance and what won't. I would say like an empathetic structure would be one where people aren't feeling like, well, I can't go to the doctor because I don't know if this trip to the doctor will bankrupt me, medically, because I don't know what will be covered by my insurance. And that's not super clear. And it's not, something where I can easily ask a question of my doctor and get that question answered.
On this topic as well, and I think of like how I think we see a lot of that care in other countries. Like here is such a capitalistic society, like thinking of how much we spend on healthcare and the return on that when you look at like so many different health issues in communities and in people and kids, and just like with the expense that you was talking about, Jayla. But in other countries, like they get it right. And even when it comes to, I know I'm getting out there, but like when it comes to like gun safety and things of that nature, I was just talking with someone that went overseas, and they was like, they don't have to really care about shooters and things because people just didn't have guns there. And so, just thinking of where it's more emphasis on the social needs, the needs that are pertaining to the people having their care first, and that being supported without the big pharma and the investors that is looking at the bottom line and things of that nature. So if in a perfect world for care here in the States, if we can remove that factor from it and really get to how we are showing up and really being empathetic about providing the most appropriate care at the right time for the individual, we would be essentially where we've seen other places of the world that's really doing this thing successfully.
I think to me, a lot of times the inequities come from structural racism and come from, structural classism. And well, they really come from, a white supremacist system that's patriarchal and homophobic. But such a huge issue that comes from all of that, the violent structure, is lack of resources and lack of care for people that have resources within our systems. It costs too much. I don't think anyone in the US can really afford to get seriously ill without it costing, hundreds of thousands of dollars. But even just going to the doctor for your checkup, a lot of people will put it off just because they can't afford it. And that has such a ripple effect on the overall health of the country. And not being able to receive preventive services makes people's health in the long run so much worse.
I appreciate you. Yeah, just kind of like naming the isms. I think to your point, and then Waylon, the point that you were making earlier, like anything that we try to do within a capitalist structure that is the larger overarching dominant culture of our country within a capitalist system, that is the system by design. But yeah, I think it's just unfortunate that that has bled over into our healthcare system. And then like, too, like all of these ripple effects on the health outcomes that the system operating this way contributes to, I think then it also like feeds into this mentality of kind of this sense of like individualism that feeds into like this weird individual responsibility thing that happens when it comes to people's health. I don't know. It seems like whenever a conversation is brought up about, well, like, why is this one particular community facing this one particular health outcome chronically, there's always that two sides of the conversation that come up that's like, well, that's just how that community acts, and then that's feeding into stereotypes. And then yeah, it feels like it's so hard every time to move the needle of the conversation over to like, no, it's not how that community, like, it's not just their health behaviors, it's because of operating in a capitalist structure, our healthcare system therefore is very responsive rather than, or reactive rather than proactive, where folks don't have access to the preventative resources that can keep them from injury and illness in the first place. I think that's just another interesting and critical element to the conversation to understand that, like, this is why our healthcare system, unfortunately, feeds into that structural violence piece, because capitalism has bled over into the healthcare space and then fed into that mentality of that some people just don't deserve to have health because they can't afford it. And people thinking that health is a privilege when it should be, if we're talking about ethical, how humans should be treating other humans, health is a right.
Yeah, I'm also in agreement with everyone has said, and I want to give an example. So I was an intern at Wake Forest Baptist Office of Cancer Health Equity, and I worked closely with the Downtown Health Plaza out of Winston-Salem. And that around that time, they had a panel of like 15,000 Medicaid patients, and they had seen because I did work for the Office of Cancer Health Equity, research has said the use of cigarettes is directly correlated to lung cancer. And so they had a really high number of patients or clients that were smoking cigarettes. And they were like, well, we have the quit line form, we have all these things. But they also had a great number of Hispanic patients too, but they had a quit line form and it was in English. When we think of, what does equitable practice actually look like practical, I know we've talked a lot about the issues of our system, but like, what can we do? Simple things like translating documents so that people that do have language barriers can still have the right and access to resources that are readily accessible. How can we put hard stops in our electronic health records? When a patient comes and they're checking in, how do we screen for these types of things just in case there is no opportunity in the visit for us to engage in that way? Those hard stops, those notices of like, okay, the patient indicated that they are a tobacco user and they're also interested in quitting, because majority of the time when we go to the doctor, they're always asking us to fill out something. One thing about it, they're going to make sure that insurance is up to date and that address is up to date. And if anything is changed, they're going to ask you every time. And so just like we put just as much emphasis on that, we should also do that when we talk about like the social context that people live in, or just, hard stops to assess if a patient are using tobacco, or if a patient has a language barrier, being able to provide resources for them and not saying we don't have resources for you without saying that we don't have resources for you because we don't have them in your specific native language. There's some intentionality as far as system-wise that we could do, but it takes more than just an idea or just a circumstance or a case for one. That's one clinic, and there's plenty of clinics in the state. So that's something that I seen that was actual practical experience that I had. And I was so happy to be a part of that because I was working as an intern with the Office of Cancer Health Equity. And so when we think about cancer health equity, that's another layer to health equity. We got cancer added on to it, which is a disease that metastasizes and manifests really rapid and really quickly. And so how can we be more intentional with our preventative strategies when it comes to our electronic health records? That's a question I have for the system. Probably not a question we're going to answer here, but as we think about solutions rather than the issues, because we know the United States of America has struggled in many areas, and then we've done great in some areas as well. But when we think about equity in healthcare, it's rough around the edges, but we're trying. And there are smaller clinics that are willing to do the work, but that also took them having a director that had a master's of public health. And so she took that perspective and she understood. A lot of times when you just study molecularly, you don't think about whole person. And so that was a practical experience that I've had specifically with a clinic where they actually practiced equity in their standard practice.
I think that point is so important, especially when you bring up low English proficiency, and then you also bring up leadership as well. With the low English proficiency, that population falls through the cracks a lot more because even with translations and things like that, a lot of that is very cultural, language is. And so you really need somebody from the community to really reach out to that population and to make sure they're getting the information correctly. But when you talk about leadership as well, leadership has to be on board for these changes, or things aren't going to change because they can assume everything's going fine, especially if they're not, listening to the employees who are interacting with the patients every day and advocating for their needs.
Our next question is, what does it mean to lift community voice in your work?
So my background in public health is more in like the food access, and social justice more on the agriculture, urban farming, that kind of side. So in some work that I was doing with a local food policy council, where one of their key programs was supporting farmers markets across the county that were serving a SNAP Double Bucks program. If folks haven't heard of Double Bucks, it's a program that allows for folks that are receiving SNAP benefits to be able to shop at farmers markets and double their dollars, with the idea of creating more of an opportunity for access to fresh, locally grown, healthy fruits and vegetable kind of food. In the process of doing that program, and something that speaks really well to like the structural empathy that we were talking about earlier, is they and I kind of helped to make the process a little bit more integrated, but they were really good about doing multiple times a year community surveying at the farmers markets that were supporting the program, to be able to be getting that input directly from folks that the program is trying to serve, and creating a regular field for gathering that feedback and input. And it was something that was so consistent that I started to see, like when we were analyzing survey results over time, just started to see kind of where members were like looking forward to when the surveys would come out, because they knew that there was going to be changes coming after the like, small tweaks and stuff, whether that meant like changing something about the style of the tokens or changing but basically I say all this to say, I think it was very fulfilling from the perspective of like equity kind of just being a process and not a destination, but to see where community members were looking forward to like that survey and looking forward to having a space where they were really knowing their opinions were going to be heard, and like there was going to be a response after. Because I think a lot of the times too, like this is something that we might not realize as a channel for unintentional harm within this work, but like if you're going out and doing community surveying and then not doing nothing with your survey results, or doing complete opposite based on the survey results, or skewing the results to, make it so that you can go and do the program that you wanted to do there anyway, the community is going to peep, and recognize that. And then essentially like you're creating a mechanism for more distrust to grow.
I really, really agree that that's so important, because I think we were talking earlier about like collecting data and having hard stops through the EHR. The FQHC that I worked at previously, we did have a lot of hard stops in the EHR, and we did ask a lot of questions about the social determinants of health. And there was a limited amount of things that we could really do for the patient, depending on if they answered that, you know, they were in need of those services. So to some degree, you know, I always kind of wondered like what the patients really thought about that. Like, if you're getting those questions asked and then you answer, yeah, I don't have enough food at the end of the month, and the person, you know, checking in is just like, oh, okay, I'm just going to check this box about it. How does that feel?
Exactly. That just feels like, or could be a way to make it feel even more, you know, create more harm, or make it feel even worse, because it's kind of like, you know, we don't know what level of vulnerability or transparency that individual had to access to be able to share that with the provider, you know, like, and then to feel like, oh, they just wanted a piece of my information and not. And I think, you know, also where we have conversations about community data and just what it means for our healthcare system to be gathered. Healthcare technology, you know, we know that lots of different systems at this point are collecting information and data on us, but especially, you know, in a health setting, be collecting all this information and then still feeling like your health needs aren't being met. But it's like, look, y'all have every piece of information. Y'all know more about me than I probably even know about myself, and I still am not getting the care that I need. What does that look like? And, you know, where these healthcare systems can then use that data to go and get large amounts of funding, you know, that are supporting their work that they're doing or their community outreach, but we don't think about what does that mean actually to communities that are not having their health needs met. What does that mean as far as like data ownership? I know personally, like if my health information is being used to help somebody else get paid more, you know, get paid that has nothing to do with my health improving. I personally don't, I want to be involved in some decisions about where that data is going, at the very least.
Exactly. And I completely agree with that, Jayla. And I think too, you know, it boils down to individually and collectively telling your story. You've seen a lot of examples of institutions that use data and will be able to portray your community and your needs in a specific way that benefits them that may not benefit the community at all. Coming from, you know, again, you know, I'm not gonna beat the dead horse about being a rural community, but you know, we get called, you know, we're a tier one community, we're marginalized, we're all of this, but it's like, you know, we at the end of the day, like we are people, we are empowered. And I'm glad, you know, I was so glad when people I think it was the rural center. I was there and they was like, you know, we are no longer using the word resilient for communities that have fewer resources. You know, we are tired of just being resilient, having to overcome and just, you know, not really like we know that, but when is it going to end? And so community voice is so vital because like Shaughnessy says a lot, it's, you know, we have lived experiences and that's our tool at the end of the day, because we are experts at this knowledge, at our experiences, and, you know, we have to make our own way. And that's, you know, that's one of the things that I like for people in the community, especially here, to realize is that it's power in our voice, and the change starts with community, the elected official level, at the policy level. And I think that's important too when we are thinking about care, because some of the best care that I've seen working at the health center is when providers take the extra time to listen to the majority of their patients. And there would be certain things that we would be doing operational wise, and, you know, providers will say, well, you know, I got a lot of patients saying, hey, this isn't working for them, they're feeling this particular way, and, you know, in this community we may need to rethink this. And, you know, it made me feel really good, providing that care in the community that I live and was born and raised in, because, you know, that's when I was like, okay, well, we really have people that genuinely care, that's really tailoring this care to the needs of the community. And you know, it's person-centered care at its essence. So yeah, community voice is needed. I'm grateful that, care share is very, very serious, and we really take that to heart. And that we are intentional about our approach to how we utilize and leverage community voice, because in the wrong hands, it can be detrimental to communities as well. And even when we think about how communities is portrayed, kind of leaving the area of health, but here in Ahoskie, we had a lot of shootings, and we have people from Raleigh and people that look on Facebook and say, "Oh, well, it's a war zone in Ahoskie. We don't want to go there. It's you're going to get shot just coming outside." And things on social media can go different ways so fast that they can become the narrative. But one thing we've been saying is that we gotta do more positive things. We gotta put more better energy into the community so that we can kind of bring light to some of that darkness that comes throughout the community. And so one of the things with communication that I'm glad that we had discussion about was the storytelling that we are doing, and being able to let communities tell their story and organizations tell their story. And I feel like, from it's a lot of different ways we can look at that from the community and also from individual standpoint, getting in there in the clinic with a provider, being empowered enough to talk about those lived experiences for the care.
I feel like from a communication standpoint, since you brought up the storytelling, that's always the most important work that I can do, is to share either the community or the organization story, like we did in the Community Voices Making Change video series, or when we did the NC BIPOC Leader series as well. That puts the human element into it so much, but also at the same time, it's such a privilege, both as an organization and, for me in my role, to have people willing to share their story, especially the people who are willing to share their story because they also want to spread awareness about the things that happen to them so that it can also impact their community.
Yeah, and I think it's worth pointing out too, like we come from this perspective, and like throughout this whole conversation, I think we're all talking about our lived experiences that led us to having certain encounters, or led us or our family members or our loved ones, or people close to us, to having encounters with the system that were displays of that structural violence. So I think, coming from the perspective of being able to like directly relate to if the systems were changed in these kind of ways to be more empathetic, this is what that looks like. I think that also allows us to come from, just a helpful perspective, and then also like a space to be able to neutrally like bring others into conversation that might not see it the same way, but I think that's another thing too. That's how we get to real systems change, understanding like what way do you see it and why do you see it that way, and how can I utilize my lived experience as leverage to help grow the general understanding, of like, just because that might not have been your experience because you're operating from a place of privilege doesn't mean that like we can't change things for the better for all.
So uplifting community voice for me really looks like being intentional. It's not just like a space where you're collecting. Like so many communities have been through this. Like I know previous we were talking about like data collection, everything like that. Qualitative data is data, and lived experience is data. And a lot of times people use data to paint a picture rather than to strategize, to develop solutions and take it to people who actually have like big influences on policy, who create policy. And so for me, elevating voice means not only having those conversations, going into the community, really understanding lived experiences, but using it as a mobilizer of the work to advocate for systemic change. Because too often we just grab qualitative data and use it as a case, most likely a business case in the United States of America. But just really being intentional with what is the what, the so what, and now what. Now that you have this story, now that you understand this community's voice, now that you have data that's precious, what are you going to do with it? What does that mean for them? What is the ROI of me expressing my lived experience and telling you about my community and inviting you in to really hear about us, what are you going to do that's going to bring my community back benefit? And I think for us as an organization here at CareShare, we've been trying to be super intentional with what does that look like, right? So what is the now what? What are we doing now that we know? And so if that looks at the community's assets and try to aid in the building of the capacity of their assets, then I think we're committed to that. But too often are we collecting data and using it as a business case, but not as a business case to go back and help and change the same very things that they're expressing to you that's an issue in their communities.
Yeah, Shaughnessy, and I think one other thing too, like I feel like to what you were saying, that we do really well across the board, like as an organization, regardless of what program or initiative we're working on, starting with like, I feel like whenever we're starting to brainstorm any new project or initiative or anything, like we're really thinking about how can we start with the community, like how can we start with community input first. So before any of our own assumptions or opinions or, you know, any of our even own like lived experience can influence like how we are going about actually developing that program, we're thinking to like, hey, let's run the initial idea by somebody else, you know, whether that be us going to our board, you know, and going to our board and asking for them to gather input from their networks that are a little bit more close to like the community, that grassroots level. But yeah, I think yeah, just as you were saying that stands out to me as something well we do, like regardless of what program we're working on. And then I'll say like specifically within what's coming to mind for a program that we're in the process of like still kind of building out. So we are doing a lot of that community listening is with our Pathways program. Our intention behind it is to create more opportunity for BIPOC students to be able to have a supported internship experience that is, one, helping to hold their institution more accountable to supporting their internship experience and supporting their transferable skills to the workforce, and then two, preparing them to be a leader in the healthcare field with the idea of students that are coming from marginalized backgrounds. We're wanting to get more of that voice into these healthcare decision-making and leadership roles so that the outcome of that is that, you know, these decisions that are being made within the healthcare field and sector are informed by folks that historically like have been negatively impacted the most. So yeah, creating more of that opportunity to do that, starting with the program, we have completely since the beginning started with gathering students' perspective, BIPOC students' perspectives. I feel like when we first were initially hosting interviews and focus groups for BIPOC students, like the way that students were like, wow, we've never, like, you know, that this isn't too frequent, where like people are asking for our feedback and our feelings about having to do an internship. And you know, as we all know, a lot of times, unfortunately, operating in this capitalist structure, an unpaid internship after you've had to sacrifice like who knows what for 4 years or more of working towards a degree, and then have to sacrifice time for an unpaid internship that may or may not, you know, be directly correlated to the things that you actually, the skills and characteristics you actually want to get out of that internship experience. That just comes to mind as one specific example of like how we've started with the community that we're trying to impact, started first with their input before even like building out the program.
I think also like what we have to consider is in the work of health equity or equity in general, everybody has a role. And just because we work in equity space doesn't mean that we don't have lived experiences that have been inequitable to us. So everyone has a role, everyone has lived experiences, and there is value in understanding lived experiences and what's the everyday context for certain communities for all communities outside of our own, and really just giving them that space. And it's not just a mic and say, okay, this is a town hall. What's the strategy, right? Like what's happening afterwards? Like, now that you all know, now what? Because a lot of people don't talk because there's no action after it. And I think us as an organization, Jayla alluding to one of our programs, me alluding to what we're doing as far as with specific communities, you have a responsibility, right? You have to, and you're not going to be able to fix everybody and everything. But when someone shares something with you from a community, they're coming to you with the expectation that you know something, or you can connect something or someone to make a change or difference if it's something that's detrimental to the community. You don't just go into communities and collect data, because that does the community no benefit besides maybe awareness if they get if y'all get published, or the organization or the research university gets published, and they've been talking about the community, but there's no really benefit besides awareness. What does advocacy and health equity and action look like when you learn? Like, when you learn and when you hear and when you talk to these communities, what are you actively doing? There's too many resources in this world for us not to, reallocate where they are going, because we know that because of the history of the United States of America and the history of oppression and structural racism and all of that, that there has been a misallocation of resources. There's resources here. We have just allocated them, or systems have allocated them based off of the best business case rather than for the people. I think we should be more for the people than the money, even though it takes money to do things. We got to be for the people.
And our final question is, when it comes to white supremacy culture, what is your lived experience with it, and how do you see ways to dismantle it in your work at CareShare?
I can physically feel a difference from not working in white supremacy culture. And I think when you know at your core the structural violence, it exists and you're within that system, it takes a different type of toll on you. I've seen it from so many different levels, but I knew when I was doing everything in my might to just to have a seat at the table by somebody that just walked through the door and I'm here, like it's never enough. It's to the point where you're rushed. It's the sense of urgency, and also the lack of accountability. It's just so many different aspects of white supremacy culture that lives through systems. This is the reason where there's silentness and collaboration doesn't exist, and the voice isn't given to the community. I mean, it's where we are right now. We have a long way to go, but I do see the tide turning. I will say, I'm happy that we are being able to partner with other organizations and funders that are rethinking how they approach even funding organizations. Looking at the organizations that are rooted in equity and justice, and also how they are engaging with community members. We was talking earlier about the structures and how racism built these barriers long ago, and they're still here now in 2023. And even driving through my community, every town has a railroad track, and just being able to visibly see what white supremacy culture and what redlining and things of that nature has done to the community, and then you think about how that trickles down to health, how it trickles down to these missions that organizations are charged with doing. It runs deep, but I think now we do see people that are being brave enough to step up and do something about it.
Yeah, I think too, just to you, Layla, like you were saying, like specifically being able to name racism as the root. And we know in the midst of what the last several years in this country have looked like after the murder of George Floyd, we know that it takes the work of not just not being racist, but being actively anti-racist to change the tide of I think the direction that systems in this country are trending toward. And yeah, I think being able to explicitly name within our strategic plan, like that we are disrupting white supremacy culture, that we are restructuring our organization internally to be able to ensure that we're putting our money where our mouth is and truly not just talk about the work of being anti-racist or talk about the work of equity, but truly strategize for ways to put that into action. Like you were saying, Waylon, like for this being the first time in my professional career to have been a part of an environment, an organization like this, you feel the difference. Especially like just speaking from my experience as a Black woman, like, you know, a lot of professional environments that you're like preparing to walk into, like 9 times out of 10, like, you know, I'm preparing for, okay, what are the microaggressions going to be? Like as a Black woman that has been in predominantly white environment for most of my like upbringing and academic career, you're preparing for what are the microaggressions? What are the, you know, having to explain or qualify my lived experience and dealing with having to like dismantle systems while also dealing with those things in your everyday life. It's exhausting. That can be very exhausting. Being able to be a part of an organization that really takes a look at the characteristics of white supremacy culture and where we can have transparent conversations about if we are playing into characteristics of white supremacy culture, because characteristics of white supremacy culture affect everyone, no matter if you're Black, white, anything, they permeate everywhere. Being able to have those conversations internally as an organization, I think is just refreshing, and it's very rewarding to be able to have these similar kind of conversations with other like-minded organizations that are also, that's a central value.
I feel like for me, when it comes to CareShare and then us being able to explicitly name white supremacy culture, you know, within our strategic plan, and it's on our website, and using that language is almost kind of like a weight is off your shoulders when you're addressing equity issues, because you don't have to look the other way and pretend that this reality isn't there, when you can really kind of get to the heart of what the cause of this issue is. When we want to make systemic change, you know, when we're working with these structurally racist systems, you know, unless you address the inherent racism within the system that's there from the very beginning, that's legally there, that was intended to be there, was intended to benefit white individuals and harm individuals of color, then you're never really going to get to where you can even, you know, build another foundation for change, because everything is trying to work around like this, you know, kind of like white lie about where the problems are coming from, and it doesn't address the source.
Just to end the conversation, I wanted to ask, what is it you think we're doing at CareShare that's dismantling white supremacy culture?
I would say we do a lot, but just calling it out and being intentional and vocal. One of the things that I'm really excited about, you know, Shaughnessy is leading our efforts with community strategists, and knowing that we have a board that is in full support of this work and support of how we approach it as well. You know, one of the things is giving power to the people that need it most. We've been seeing a lot of disenfranchised communities and populations, and looking at the communities that are suffering now because of white supremacy cultural practices, and working with them, helping to empower. You know, we talked about lifting their voice, make sure that it's lifted to the right destinations and lifted in the right way. So a couple of different ways that we're going at it, but I think that intentionality part and being vocal, making a stand, and also holding ourselves accountable. So, you know, the development of that community strategist board is making sure that we aren't instilling any white supremacy culture practices within our own organizations and how we show up to community and to meetings and to partners and to things of that nature. So, that accountability factor is very important to me. And, it's a lot of different ways that we're going about it, but I think this is, it's a start for us.
I think also the concept of the accountability to the community and wanting to collaborate with the community and making sure that we receive their feedback. That's something that takes a little bit more time. And white supremacy culture is so focused on results and results like with speed to the point where even if it's not the best way to go about it, it got done fast and it got done. And that's what's so important. And so I think with the community strategist, that's something that might make the work a little slower, but it's definitely going to be more comprehensive and it's going to reflect better what the actual needs are that we need to address.
I think one thing too, just to the point earlier about, the characteristic of white supremacy culture to like that sense of urgency that puts getting things done fast over getting them done right. I think also too, just in the nature of that community strategist work. And I think even to where I was talking about our pathways program, just operating with that sense of lifting community voice in all that we do. Something else too that is a central value of CareShare is collaboration and partnership. So I think shifting the white supremacy culture characteristic perspective around like that urgency to have it done fast, shifting the perspective to like more of an urgency to have it done community centered is something that we're doing that actively, I guess, like counterculture to that particular white supremacy culture characteristic. Just amplifying and emphasizing that point that you were making earlier, Erin, of like, even if that might mean that it takes longer or might mean that, starting with before we even develop a program, like we're getting the community input, and that might mean that we have to take it back and workshop it and take it back to community again and have them see the changes that we've made and then give us feedback to that. And like, kind of engaging in some of that back and forth. While it may feel like a longer process, like it's also within that process, we're building trust with community, because I think it's a different tone when someone from outside external to the community is coming in and they're like, do this right now, right? We have a grant deadline to meet. So like, you have to do this, you have to give us your input right away. For me personally, if somebody was coming to my community and responding like that, that's going to be, oh, nope, I'm shutting down. And that's giving me less of a reason, to give what they're asking. So I think also being intentional about doing it in a way that's organic again, and truly trying to build a relationship that's centered on trust and centered on that community feeling comfortable with how we've gone about approaching them. I think that's a factor in it too. And in the work that we've been doing, I think, I've been with CareShare long enough to see like sometimes moving in that kind of way, partners that we'll try to work with that don't necessarily value or are more attached to valuing that concept of urgency rather than like having it done right. Sometimes that creates some friction within those relationships and partnerships we're trying to build too. But yeah, just us as an organization being able to remain steadfast and committed to that value of starting with the community first and ensuring that nothing that we do isn't done without being community informed is something, that I guess just stands out to me about what we do really well. And again, because it is counterculture, it might not always make sense to, to others, but I think it makes a lot of sense to us. And I'm glad that we can continue to operate in that way. And then I think it also reflects internally in our work culture and how we show up, are able to treat one another, like as a staff, as a board, as a team at CareShare with that same level of respect.
Thank you so much for listening to the first episode of the Equity Plus podcast. We hope you enjoy the conversation and be sure to subscribe to hear more. To learn more about CareShare Health Alliance, visit us at caresharehealth.org, and don't forget to check out our hub for community-based organizations working to promote health equity and community voice, the Equity Plus Network, at equitypn.org. That is EQUITYPN.org. We can't wait to connect with you there.